Management of ocular surface squamous neoplasia in association with fungal keratitis in an HIV-positive individual. I have no financial disclosures or conflicts of interest. A 42-year-old male presented to us with the chief complaints of a whitish growth over the cornea of his left eye since the past 4 months. The lesion had started off as a small painless papule at the limbus and then gradually progressed over 3 months to encroach the cornea. He had initially taken over-the-counter topical steroids for 3 months and had reported to us only when the lesion had become significantly painful with a decrease in his visual acuity. His uncorrected distant visual acuity at presentation was 20/20 in the right eye, but only 20/600 in the left eye. Examination of the left eye on slit lamp revealed a mixed leukopaque lesion of size 4.5 by 6.5 millimeters overlying the cornea, along with a papillomatous lesion of 4 by 14 millimeters overlying the inferior and temporal bulbar conjunctiva with overhanging keratin straddling the nasal and the inferonasal limbus. Multiple dilated and tortuous feeder vessels could also be seen. A diagnosis of OSSN was arrived at. However, along with this lesion, there was also an ulcerative lesion with 4 by 3.5 millimeter infiltrate involving more than 2/3 corneal thickness with feathery edges overlying the visual axis. On gross slit lamp examination, the phonesis were unaffected. There was no enlargement of the preauricular or submandibular lymph nodes, and the inferior and temporal bulbar papillomatous lesions took rose Bengal stain, highlighting the extent of involvement. Because of such an extensive lesion in a young male, he was screened for HIV 1 and 2 and was found to be positive. Corneal scraping also revealed separate hyaline fungal filaments. To treat the fungal ulcer, he was started on hourly natamycin along with homatropine 2% thrice a day. After obtaining a normal LFT, he was also started on oral ketoconazole. He was counseled about his immunodeficiency and started on heart therapy after checking his CD4 counts. To manage the OSSN, after 1 month of treatment with antifungals, his ulcer had resolved. The corneal scar had become evident. After performing an ASOCT, the OSSN was seen to be confined to the epithelial layer and he was started on topical interferons 4 times a day. After 3 months of interferon, the lesions across the bulbar conjunctiva had resolved completely, leaving behind only stippled pigmentation. However, the lesions over the cornea and the limbus were still present. At 5 months, it could be seen that even these lesions had resolved completely. He was continued for interferon for 1 more month, and to this date, he has completed 2 years of follow-up without any recurrence. Coming to a discussion, a case series of 60 patients with concurrent OSSN found that they were positive for HIV in 38 to 41% patients. However, 70% of them were unaware of the HIV positive status. As we know, there are several risk factors for fungal keratitis. Our patient had risk factors like previous use of topical steroids, a poor ocular surface, and HIV positive status. In this case, the tear film distribution abnormality because of the OSSN could have led to Delin formation. Also, non-resolution of the OSSN could have led to epithelial breakdown and ulcer formation, which could have become secondarily infected with fungi. Literature also reports that there was 1 case which could not be managed medically and extended enucleation had to be performed for that particular case. However, in this case, the patient had a pre-existing fungal keratitis. OSSN had developed later on. To conclude, immunodeficiency in HIV infection predisposes an individual to development of OSSN as well as infective keratitis. Therefore, all patients with OSSN should be screened for HIV. The epithelial compromise caused by both pathologies makes management difficult. However, sequential management with topical immunomodulators continued for 1 to 3 months beyond clinical resolution of the OSSN is effective. These are my references. Thank you.